everyone to another episode of the Rucklab podcast series. My name is Volen Ivanov and I am a licensed psychologist and a PhD student running the hoarding project in our lab. Today I'm in New York and I have met up with Dr. Anthony Pinto, who is an assistant professor of clinical psychology at the New York State Psychiatric Institute and also an expert in obsessive-compulsive personality disorder and the relationship between OCPD and OCD, obsessive-compulsive disorder. So let's start off with quite a simple and basic question, Dr. Pinto. What is OCPD, obsessive-compulsive personality disorder, and what would you say are its most prominent features?
Okay. Well, thank you, Volen. I appreciate you meeting with me today, and happy to participate in this podcast. We're, like we were saying before, interested in talking more about OCPD to get the word out and increase people's awareness of this condition. So OCPD is a constellation of maladaptive personality traits that leads to functional impairment or distress. The core features are, in my view, are perfectionism, which can interfere in completing tasks. So the individual is, relentlessly pursuing unattainable standards, even when continuing to pursue those standards leads to problems, and that they're also over-evaluating themselves based on their ability to attain those standards. So their self-worth is strongly affected by their ability to meet these standards, which are, like I said, not attainable. So the perfectionism is one, and then the other part is rigidity, which causes them significant interpersonal problems. So they have difficulty, having a meeting of the minds with other people, or it can be difficult for others to sway them from their strongly held beliefs. So those are the two cores, and whenever you do factor analyses of like the DSM criteria, those seem to be the two major factors that come up. But then there are other pieces that are important as well, as covered by the DSM, like preoccupation with order and details, lists and schedules. Excessive devotion to work. These are people that are going to feel uncomfortable when they have downtime. They often choose to participate in work activities over social and leisure. Those things, and some associated features that are not actually in the DSM are things like having difficulty with change, and so they feel most comfortable with routines. They are excessively rule-bound. They have another piece that is not in the DSM, but I think is really important, is that they're this emotional over-control. So they have difficulty sharing emotions and tend to be constrained in that. They can have anger outbursts when their sense of control is threatened. And then the other piece is procrastination that leads to great problems at school and at work, and that seems to go hand in hand with perfectionism. Mm-hmm. So those are some of the core clinical features of the disorder.
Mm-hmm. And I know that OCD, obsessive-compulsive disorder, is sometimes mixed up with OCPD, and this is not only done in the public but also among professionals. So could you speak a little bit about the difference between OCD and OCPD and the commonalities between the two problems or disorders?
Sure. Yeah, like you said, whenever I come in contact with professionals, they tend to confuse these conditions. There is certainly a relationship there between these conditions, and about a quarter to a third of people with OCD will have comorbid OCPD. There's also a relationship in terms of family history. The individuals with OCD are twice as likely to have relatives or a family history of OCPD as compared to control probands. So there is this relationship based on familiality and comorbidity. There's also overlap in terms of some of the symptom presentations, and so, as for example, ordering rituals or symmetry-related rituals in OCD can overlap with the preoccupation with order and details that you see in OCPD. Some people with OCD describe this uncomfortable internal feeling, which we call incompleteness, and there seems to be an overlap there with perfectionism in OCPD. Traditionally, the disorders have been differentiated based on ego-syntonicity, and so OCD is considered to be an ego-dystonic disorder where the individual reports intrusive obsessions, that are unwanted and distressing, whereas somebody with OCPD, a condition which we tend to consider as ego-syntonic, they would view their behaviors and their to be appropriate, correct, and oftentimes they would their worldview they see as like the right way, and so they would want others to be that way as well. But it leads to problems because they're not able to achieve, or they're they have difficulty in their social interactions. So that's been the clinical guideline for differentiating these disorders. But in my own work, where I've characterized OCPD versus OCD, I find that the presence of obsessions is a distinction between these disorders, where with my patients with OCPD do not report these kinds of intrusive, unwanted thoughts. And then in terms of cognitive neuroscience, some of the advances there are now allowing us to compare the disorders using neurobehavioral probes and looking at neural dysfunction. And so one area that I've been looking at is this concept of delay discounting, which is an index of one's capacity to delay reward. And in a study that we hope to publish soon, individuals with OCPD had a greater capacity to delay reward as compared to individuals with OCD. And so this is just one way of further differentiating these conditions. And so we hope to develop this work more and see if there are distinctions on a level of imaging, for example. And so we're trying to take advantage of some new advances in our field to look at these conditions. So in a nutshell, there is a relationship, yet when you look at these things more closely, these are distinct patient groups, and we're trying to investigate that further.
Mm-hmm. And another thing that I've been thinking about is the relationship, because when you describe the prominent features of OCPD, they kind of resemble, not entirely, but resemble some of the features in autism spectrum disorders, Asperger's syndrome previously. Could you tell us something about the link between the two disorders, if there is any at all?
Mm-hmm. Yeah, I think because of the difficulties in interpersonal functioning, this is one reason why people may consider some relationship there. My sense of this is that in the autism spectrum, the deficits in terms of interpersonal functioning are going to be probably like more profound and maybe more wider reaching, whereas in OCPD they seem to be more specific deficits that have to do with perhaps emotional expression, so there's greater control of emotions. But my data suggests that they do not actually have any deficit in terms of identification of emotions, and so in the rigidity piece is an area where that causes problems for them because they tend to be very insistent about their worldview, and so many of these patients will say things like "it's my way or the highway," and so there's often an insistence on one way of doing things, and that leads to to friction with other people. But they do have the fundamental capacity to engage in relationships. Yet the personality pathology of the rigidity, in combination with the emotional constraint, leads to stiffness in their relationships. They tend to want to be able to control relationships or predict relationships. Whereas my sense is that in the autism spectrum, there's there's a greater sense that those patients are lost in these relationships, and because of their deficits related to how they relate. So that I think are just more generalized.
All right. Now, hoarding was until recently, before the DSM-5 came out, an OCPD criterion. But what is your take on this? Is there really a link between OCPD and hoarding?
Yeah, I think that the hoarding criterion has historically been associated with OCPD, but in terms of empirical data, I don't see a specific link between hoarding and OCPD. In characterizing individuals with OCPD, I've not seen an especially high prevalence of hoarding in these patients. When you look at factor analyses of the DSM criteria for OCPD, hoarding doesn't doesn't load on the symptom factors very strongly. So I don't think there is lots of justification for hoarding being part of OCPD. And my understanding is that the proposals for DSM-5 for OCPD were to not include hoarding as on the symptom list, and now they've decided to stick with the DSM-4 criteria. So I think that in time that probably will not be seen as an important feature of OCPD.
Okay. So OCPD, personality disorders in general are considered to be difficult to treat. Is there any treatment for this condition, and in such case, what does it consist of?
Yeah, despite the fact that OCPD is considered to be one of the most common personality disorders, and there's also data to suggest that people with OCPD seek treatment at higher rates, both in terms of medical care as well as psychotherapy. Despite that, there's no empirically validated treatment for OCPD. There is a long history of in terms of OCPD being known about or are described in the literature that dates back to to Freud and perhaps even before, and so there have been suggestions of how to treat this in the literature, but no definitive empirical study that has pointed to one particular treatment modality. And so that's something that I've been interested in, and I've had family members as well as patients that have been very interested in pursuing treatment. And so what I've been working on is looking at some of the core features of OCPD and trying to map those onto treatments that have been developed that could be modified for OCPD. And so based on the difficulties in terms of emotional control, I've been working with an emotion regulation protocol and combining that with a cognitive behavioral treatment for perfectionism, trying to get at the interpersonal problems and these emotional constraint problems with the difficulties with perfectionism that interfere in their work or school functioning. And so this is something that's we're testing now and hope to publish. But I think that this kind of combined approach of looking at interpersonal functioning as a way to teach these individuals skills for garnering support from people in their lives, and as well as giving them skills for enhancing the work relationship or the therapeutic alliance with their therapist, which in the depression literature we know that OCPD leads to alliance ruptures, and that leads to poorer outcome. So giving them the skills to engage in relationships and in a flexible way, and then once you've established some of those skills, moving on to trying to tackle the difficulties with perfectionism or rigidity and some of these like entrenched behaviors that they have, and then using CBT approaches to try to modify some of those things, and trying to get them to release some of these rules or standards that they hold on to, and using things like exposures or behavioral experiments. So that's the work that we're working on now, and so we hope to further develop that.
Yeah. All right. So thank you very much. I would like to end on this hopeful note here with the treatment question. So thank you so much for taking the time to answer my questions, and of course I wish you the best of luck with your future research. And I would also like to thank our listeners for listening to this podcast, and I would like to mention that you can follow us on rucklab.com, where you can read about the latest of our research and also listen to other episodes of this podcast.